Hello everyone, my name is Ifrat Jahan Tinny. I'm currently pursuing my bachelor's on microbiology from Norfolk University. Today I'll be presenting on a revolutionary article named Individualized Medicine, Sex, Hormones, Genetics, and Adverse Drug Reactions. Firstly, I would like to thank all the respective participants and especially Biocan Academy for providing me this stage to present on such thought-provoking article. So to start, we have to comprehend a few words to elaborate this article better. Um, Individualized medicine and individualized medicine means how a person's genes respond to specific medications. Adverse drug reactions, shortly ADR, is unwanted effects of drugs. Constitutive aldosterone receptor, or CAR, it's a type of hormone that primarily functions in sensing and xenobiotics such as chemicals, drugs, pesticides, etc. CYP, cytochrome P enzymes, it's a type of enzyme that mediate metabolites the xenobiotic substances. Fluctuations during period, that means the change in hormone level, medication, health condition, etc. G-coupled receptors, also known as GPR30, it mainly mediates non-genomic estrogenic signaling. Then sex determining region Y, shortly SRY, it provides instructions for making sex determining region Y protein that involves alteration of the number of genes in DNA. Selective steronin reuptake inhibitors, or SSRIs, it increases the steronin level in the brain. DHEA, it's a type of hormone that mainly produced by the body's adrenal gland. Then atherosclerosis, it mainly the buildup of fats and cholesterol on artery walls. Thalidomide, it is a type of drug or sedative that's used for pregnant women for cold, flu, nausea, morning sickness, etc. Now the methodology of this paper. So after studying this paper, it's mainly a research perspective paper. So a research perspective paper mainly represents the unique viewpoints and interprets the particular topic based on existing other research or literature. So it offers novel insights and recommendations, stimulating other discussions, and critical analysis of established theories and practical experiments. Sources of the authors have used the sources like CAS, PubMed, Web of Science, and Google Scholar. Now, abstract and introduction. So this paper mainly explores the interaction of individualized medicine, sex, hormones, genetics, and adverse drug reactions, or ADR. So it discusses the influence of individual characteristics such as sex and genetics on drug responses, and highlights the importance of considering these factors in personalized medicine. The authors emphasize the need for tailored approaches to medication prescribing to optimize efficacy and minimize adverse reactions. This presentation will provide insight into the current understanding of individualized medicine and its implications for optimizing drug therapy. Our next topic is the basic mechanisms. And firstly, it's physiological differences. So firstly, physiological differences, it comes in our mind that sex chromosome. We all know that XX is for females and XY is for males. So these sex chromosomes represents the fundamental genetic difference between males and females. So genes on these chromosomes regulate various physiological functions and interact with genes on autosomes. And then SRY gene on the Y chromosome plays a crucial role in testis development and testosterone secretion, leading to the male phenotype. The AR gene on the X chromosome influences androgen receptor function, and variants can cause X-linked traits in males. X chromosome gene variants in females may result in mosaic expression. So what's mosaic expression? Mosaic expression is also known as mosaicism. It's a type of mutation when a person has two or more different sets of cell in his or her body. So in other way, we can say that suppose a person might possess some cells with 46 chromosomes while other have 47 chromosomes. Then it can occur skewed lionization due to X inactivation. It causes hemophilia A in female patients. During reproductive organ formation, sex steroid hormones are secreted, affected body size, organ size, tissue composition, gastric acid secretion, renal function, then drug metabolizing enzymes, etc. These differences influence drug absorption, distribution, metabolism, and elimination. However, preclinical studies, clinical trials, and adverse drug reaction reporting often overlook the impact of hormone status and interactions between pharmaceuticals and pathways modulated by sex steroid. So understanding these sex-related differences and other implications is really crucial for optimizing medication efficacy and minimizing ADR. Next, our topic is sex steroid signaling mechanism. So sex hormone signaling mechanisms were traditionally believed to influence gene transcription through genomic effects primarily. However, this did not explain the rapid cellular changes observed when steroids were applied acutely. Recent research has identified surface that G-coupled receptors or GPR30 is identified as an important non-genomic estrogen signaling mechanism, and it triggers a cascade of intracellular events involving P13K or AKT and mitogen activated protein kinases. These pathways have various effects, such as influencing apoptosis, endocytosis of drug transporters, then lipoproteins and liver fat synthesis. In humans, similar estrogen signaling pathway may impact pharmacodynamics and pharmacokinetic processes by altering physiological functions, including endocytosis of drug transporters. But this topic is shortly described here. Further investigation is needed to understand these interactions better. Now, how there is sex steroid and pharmacokinetic interactions with medication. So how hormones might interact with medications in metabolic pathways. So here I have attached a picture. Here it's a schematic representation of potential mechanisms through which sex steroid hormones can affect drug metabolism and actions leading to ADRs. Here, the orange circle, it representing the medication, and the blue circle here are representing a hormone that is competing with the medication. The purple symbol here, is representing as a transporter. The green symbol representing an enzyme. The blue symbol on the cell surface representing a receptor, and the blue symbol interacting with DNA, representing a transcription factor. Now, here we have in detailed discussion. So the mode of delivery and formulation can influence the bioavailability of a drug, and transdermal formulations, for example, occur absorption into subcutaneous adipose tissue. Women typically have more subcutaneous adipose tissue than men, so potentially impacting absorption. On the other hand, orally administered medications are absorbed through the gastrointestinal tract, where sex differences in factors such as gastric pH, gastric emptying time, intestinal transit time, etc., can affect the absorption. Drugs can compete for transporters into cells, affecting their downstream metabolism and availability at the drug target. And competitive inhibition for these transporter can occur when multiple substrates are present. So studies have identified sex-specific effects of an enzyme, SLCO1B1. It's a genetic variant on the efficacy of statin treatment, with an increased risk of statin-related myopathy observed in females, particularly among other carriers in the alleles. So these findings suggest that competition for transporters may result in clinically significant drug-hormone interactions. Then another enzyme, the pregnant X receptor and constitutive androsterone receptor, they regulate the expression of cytochrome P450 enzymes, including other cytochrome and in other genes. So various compounds, including steroid hormones, can activate these receptors. Hepatic CYP3A4 activity is generally higher in women than men through sex differences in the oral clearance and of CYP3A4 substrates have not been consistently reported. Now, there are some female-specific considerations for influences of endogenous and exogenous sex steroid hormones. So our first topic is pregnancy. So pregnancy leads to change in endogenous hormones that can affect drug efficacy, and certain medications may adversely affect fetal development. Due to risks demonstrated by thalidomide, pregnant women were excluded from drug testing trials. However, approximately 64% of pregnant women take medications that may not have been adequately tested in this population. Hormonal changes are noticed during pregnancy. Hormonal hormones mainly increase blood volume and extracellular fluid and influences the enzyme activity. For example, CYP to C9. For example, the activity of CYP812 involved in the metabolism of caffeine. On the other hand, the activity of enzymes such as CYP2C, C9, CYP3A4, and UGT1A4 increases during the second and third trimester. The activity of CYP2D6, another enzyme, it varies throughout pregnancy, and that may differ by trimester. So the impact of hormonal changes on drug transporter genes is poorly understood, but it may involve the activation of estrogen and androgen receptors. Now, my next topic is menopause. So, what is menopause? It's mainly the time a time of life when a woman's ovaries stop producing hormones and menstrual period stop. So during menopause, circulating estrogen decreases by about 90%, and the conversion of androgens to estrogen by adipose tissue and skin becomes the primary source of estrogen. The decrease in estrogen levels during menopause also leads to changes in other drug metabolizing enzymes. For example, the type of enzymes activity in intestine is reduced by approximately 20%, affecting medications that utilize the pathway. Exogenous hormones used to treat menopausal symptoms that can affect drug metabolism, while drug metabolism pathways can impact the metabolism of exogenous hormones used for therapy. Genetic variation in enzymes are involved in estrogen metabolism that may influence the response to estrogen therapies. For instance, the variant like SALT1A1 gene, which encodes an enzyme that involved in sulfating estrogen. It has been associated with serum hormone levels and menopausal system. So sulfating estrogen means that it's a pathway for estrogen metabolism in order to inactivate the estrogens in target tissues. The SLCO1B1 gene, which encodes a transporter that involved in the uptake of estrogen and statins, that has been linked to breast cancer risk and statin-induced myopathy in postmenopausal women. So a pharmacogenomic approach considering genetic variations in drug metabolism pathways could optimize hormone therapy for menopause and other indications. So this approach may be particularly relevant for women who undergo bilateral oophorectomy before natural menopause. So now we have hormonal contraception. So exogenous hormones like those in oral contraceptives can affect the metabolism of other medications. They inhibit multiple cytochrome like P450 enzymes involved in drug metabolism. Another type of exogenous hormone, estradiol, it may reduce the activity of CYP2C19 promoter. Genetic variation can also influence the concentrations of exogenous hormones that is used for concerted contraception. For example, carriers of the carrier of an allele are likelier to have lower level of estrogestrel hormone used in implants, which can affect its effectiveness and in preventing ovulation, um, etc. Then factors such as body mass index and duration of implant is also used in impact of hormonal levels. So understanding this individual variation in steroid hormone metabolism is very crucial for ensuring the efficacy of therapy. Um, transgender. So, transgender is a term for people who identify whose identity differs from what is typically associated with the sex they were assigned at birth. So this fellow topic here discusses the effects of sex steroid hormone therapy on individuals with clinically defined gender. So it explains that the activational effects of these hormones results in changes in outward appearance, physiology, and metabolism. However, these effects are influenced by the individual's sex chromosomes present at birth. The guidelines for prescribing hormones therapy have evolved based on reports of adverse events associated with specific formulation. For example, for trans men, individual that are assigned as female at birth but taking testosterone. So that the treatment can increase body mass index, blood pressure, serum triglycerides, then low density lipoprotein cholesterol, etc. Adverse cardiovascular events such as venous thromboembolism and myocardial infarction have been associated with testosterone therapy. And on the other hand, for trans women, the individuals that are assigned male at birth taking feminizing hormones, their risks include venous thromboembolism, stroke, and myocardial infarction. Like trans men, cardiovascular risk is higher with oral formulations of hormone. Sorry. Sorry for the noise. Okay, so evaluating the risks and adverse outcome of transgender therapy is challenging due to several factors. One is challenging due to determining the appropriate reference of population for comparison, and the other challenge arises from difference in hormone therapy formulations, age of initiation of therapy, and other medical conditions that may pose risk factors for cardiovascular events. So the ethics statement of this paper is that all the participants had their consents while documents were signed, and the published studies were performed with the consent of the involved humans. And my remarks after studying this paper is that as it's a research perspective paper, a research perspective paper contains some uh, criteria. So one was that they generate new ideas. So I found some lack there. And this particular topic needs further study to evaluate more accurate results, as the human body is a very vast topic to uh, examine or for research purpose. And moreover, the menopause, transgender, these are almost new topics. So it needs more study, more detailed research in future. And then there is the limited data uh, and more extensive research studies where required better understanding, as I said, for menopause in women, sorry, and andropause in men, depending on the corresponding age. And the transgender hormone therapy needs more cautious medication in order to avoid the physiological and internal risks. In conclusion, this article mainly highlights the importance of considering sex differences, age, and hormonal status in analyzing adverse drug reactions. Sex hormones can influence how medications are processed in body, and these hormone levels naturally fluctuate throughout life. So, however, many preclinical studies do not account for the sex, age, or hormonal status for the experimental material, and existing large databases can help identify differences in ADRs between men and women. But additional factors such as age, specific medication used, genetic variation, etc., should also be considered. So this article emphasizes the need for clinical studies to report outcomes by these particular topics to improve individualized medicine. Thank you.
Um, Ifrat Jahan, thank you. It was a thorough presentation. Um, is your paper, that's all right?
Yes.
Yes, thank you. So, কারো কোনো কোশ্চেন থাকলে এই পেপার সম্পর্কে কারো কোনো কনফিউশন থাকলে আই গেস ডিসকাস করা যেতে পারে।
I have two questions actually.
Yes.
So, Jahan, would you please present again? So, it's in your slide number 8. We would like to see it again.
Sir, I can't hear you. Can you speak loud?
Yes, present your slides once more. I have questions at your slide number 8.
This slide?
Yes. So, you talked about that pregnant women are excluded from trials due to demonstrated by thalidomide. So, if pregnant women were excluded, then why the enzymes created in the trimesters were taken in this research?
I couldn't get you. Can you speak louder, please?
Okay. So you talked about pregnant women who were excluded from these trials, right?
Yes.
So why the hormones and enzymes produced in trimesters are taken in consideration in this research?
Okay. Thank you for your question. And আমি অ্যাকচুয়ালি আপনার লাস্ট কোশ্চেনটা মানে লাস্ট লাইনটা বুঝি নাই।
আচ্ছা, আমি বাংলায় বলছি হেল্প করার জন্য। এখানে যদি বলা হয় যে যারা প্রেগনেন্ট মহিলা তাদেরকে এই রিসার্চে এই ট্রায়ালে রাখা হয় নাই, তাই না? এক্সক্লুডেড ফ্রম
হুম।
ট্রায়ালস। তো সেই ক্ষেত্রে তাদের প্রত্যেকটা ট্রাইমেস্টার তো প্রেগনেন্সির সময় হয়, ট্রাইমেস্টারের সময় যে এনজাইমগুলো আছে এগুলোকে কেন কনসিডার করা হয়েছে?
কারণ যদিও এই পুরাটা এক্সপেরিমেন্ট বা যেটাই রিসার্চ হচ্ছে, যতদূর আমি পড়ে যতটুকু বুঝছি যে ওমেনদের মধ্যে কন্টিনিউয়াসলি চেঞ্জ গুলা হচ্ছে ডিউরিং প্রেগনেন্সি আর আফটার বা থ্রু আউট দ্য টাইম। এই এনজাইম গুলো অ্যাকচুয়ালি রিসার্চটাকে মানে অ্যাকচুয়ালি ডাটা দিতে হেল্প করছে যদিও পুরোপুরি এটাকে কমপ্লিট একটা আইডিয়া দিচ্ছে না, প্লাস এটাকে আরো ডিটেল স্টাডি নেওয়ার দরকার। বাট আপাতত এই কয়টা এনজাইম তারা তাদের অ্যাক্টিভিটি, তাদের হচ্ছে হরমোনাল চেঞ্জের এগুলো সম্পর্কে একটা ফার্স্ট আইডিয়া তারা দিতে পারছে।
আচ্ছা, ওকে, থ্যাংক ইউ। আমার সেকেন্ড কোশ্চেনটা হচ্ছে আপনি ফার্মাকোডাইনামিক এই ওয়ার্ডটা অনেকবার ইউজ করেছেন। ফার্মাকোডাইনামিক মিনিংটা কি? আমি এটা বুঝতে পারিনি আসলে।
Okay, so there are pharmacokinetic and pharmacodynamic. So pharmacodynamic is actually the study of the action of drug in particular organism. যেটা কিভাবে মানে অ্যাকচুয়ালি এটার স্টাডি যেটা আমাদের বডিতে কিরকম অ্যাকশন দিচ্ছে। আর if I may add that pharmacokinetics is actually the study that interacts with মানে effects of drugs in our body.
আচ্ছা, ওকে, থ্যাংক ইউ। অনেক ভালো একটা প্রেজেন্টেশন হয়েছে আপনার।
Thank you so much.
থ্যাংক ইউ বোথ অফ ইউ। আর কারো কি কোনো কোশ্চেন আছে? হ্যালো, আপনার ভয়েস খুবই লো আসতেছে, আর একটু লাউড করলে মেবি ভালো হবে।
Can you hear me now? Hello?
You, but still it's on a low pitch. I guess if we can just higher your voice out.
Hello?
Yes, now it's perfect. You can talk now.
Ifrat, can you show your slide again?
Yeah, sure.
6 number slide.
কত নাম্বার? সরি, হ্যালো।
7.
7। আচ্ছা, জি।
I didn't get that diagram you have described that there has a blue color. Is it
আপু
hormone?
সরি টু ইন্টারাপ্ট, আপনার কথা একেবারেই বুঝতে পারছি না।
Hello?
জি, এখন বুঝাচ্ছি। জি বলেন।
বললাম হচ্ছে এখানে ব্লু কালারের যে একটা, এখন শোনা যাচ্ছে?
জি জি।
ব্লু কালার যেটা দেখানো হয়েছে এটা কি হরমোন?
কোনটা কোনটা?
ব্লু কালার?
ব্লু কালার?
জি হ্যাঁ।
ব্লু কালারটা হচ্ছে আপনার এটা হচ্ছে সেল সারফেসের উপর, এটা একটা ধরনের আপনার রিসেপ্টর। জি,
রিসেপ্টর কি সেল সারফেসের উপরে? এটা
হ্যাঁ, এটা একটা রিসেপ্টর। এটা আপনার হচ্ছে সেলের সাথে একটা রিঅ্যাক্ট করছে, আর একটা হচ্ছে ডিএনএ এর সাথে আপনার ইন্টারঅ্যাক্ট করছে ট্রান্সক্রিপ্টর ফ্যাক্টর হিসেবে।
তাহলে আপনি বলতে চাচ্ছেন ব্লু কালারটাই হচ্ছে হরমোন, আর তাহলে এই যে অরেঞ্জ কালার?
অরেঞ্জ কালার? সরি, আমি আপনার কথা ক্লিয়ারলি শুনতে পাচ্ছি না। ডিড ইউ সে অরেঞ্জ কালার? অরেঞ্জ
অরেঞ্জ
সার্কেল?
কালার, জি।
আচ্ছা, অরেঞ্জ সার্কেলটা হচ্ছে আপনার মেডিকেশনটাকে রিপ্রেজেন্ট করতেছে।
তো এই মেডিকেশনটা কিভাবে এন্টার করছে তার সিস্টেমটা কি, এটা আমি বুঝি নাই। এটা কিভাবে ঢুকলো, সাইটোসিলেট এন্টার হয়েছে কিনা এটা আমি বুঝি নাই।
আপনি এখানে এন্টার কিভাবে করেছে এই পুরো পেপারে সেটা উল্লেখ করা ছিল না। জাস্ট এটা এন্টার যে করতেছে, করার পরে যে এটা কিভাবে ওয়ার্ক করতেছে সেটা ডিসক্রাইব করা হয়েছে। সো দিস পেপার ওয়াজ কাইন্ড অফ ইনকমপ্লিট। সরি, আই কুডন্ট অ্যানসার দ্যাট।
Okay, can you show me some slides? Number 5.
Number 5. Yes.
That was 5. I'll say 6.
6.
Hello? Yeah.
জি জি 6
Yes.
আচ্ছা
6 number বলা হয়েছে যে after the transcription through storage response element on a specific state. এই লাইনটা বোঝানো হয়েছে আবার বুঝি নাই বলতে পারেন?
আপু আমি এক্সট্রিমলি সরি আপনার কথা বুঝতেই পারছি না একেবারে
Hello? Is it clear now?
হ্যাঁ এখন বোঝা যাচ্ছে
আচ্ছা এখানে বলা হয়েছে alter gene transcription through storage response element on a specific state. এইটা কি বোঝানো হয়েছে এটা আমি বুঝি নাই।
স্টেরয়েড রেসপন্সের কারণে আপনার স্পেসিফিক জিনে যেই মানে মেকানিজমের কারণে যেই রেসপন্স গুলা হচ্ছে এটা আপনার জেনোমিক এফেক্টের কারণে আর কি বোঝা যাচ্ছে এরকম কিছু একটা
alter gene যে জিনটাতে যে ডিএনএর alter ট্রান্সক্রিপশনটা হচ্ছে এটা কেন জিনটাতে alter হচ্ছে storage response element on a specific state. A specific gene হচ্ছে alter হচ্ছে কেন?
অল্টার জিন ট্রান্সক্রিপশন এটা কেন হচ্ছে এটা বলছেন কি
জি হ্যাঁ
আচ্ছা আপু এটা আমি ক্লিয়ারলি বলতে পারবো না এখন সরি
Okay. By the way, your presentation was so amazing. Thank you for joining our presentation.
থ্যাংক ইউ অ্যান্ড থ্যাংকস ফর ইউর কোয়েশ্চেন্স অ্যাজ ওয়েল আমি এটা নিয়ে ফার্দার স্টাডি করতে বসবো অবভিয়াসলি যেহেতু এটার প্রপার অ্যান্সার আপনাকে দিতে পারি নাই থ্যাংক ইউ
Yeah. This is super.
Is anyone else there want to ask anything? Guess you covered everything. Actually, research paper হচ্ছে এই ধরনের পেপারে তো আনসার ঠিক মতো করা যায় না সবাইকে যেটা বলছি আর কি আমার যেটা মনে হয় যে ওদের রিসার্চ আমরা তো হচ্ছে রিসার্চ করতেছি না সো পেপার গুলো তো ডেসক্রাইব সবকিছু করা থাকে না ওদের রিসার্চ গুলাই শুধু মেনশন করা থাকে তো থরলি ডেসক্রাইব করা সবসময় সম্ভব হয় না আমার যেটা মনে হয় anyway it was a good successful journal club thank you Ifrat Jahan and we'll continue further and that's all for today
All right.
goodbye
আল্লাহ হাফেজ